Who's Reed? Who's the person with Reed? Well, we're gonna go ahead and get started. First and foremost, welcome ACPM board members, welcome our ACPM volunteer leaders, welcome ACPM members, friends, colleagues, leaders in healthcare from across the health and public health ecosystem. We are here to honor the legacy of a great preventive medicine leader, Dr. Daniel S. Blumenthal, and you're in for a real treat. You really are. I'm Donna Grande. I'm the CEO of the American College of Preventive Medicine, and it's just an absolute delight to have you all here today and to celebrate with us the remarkable advances that we've made, yet we still have a long way to go. It feels like it's been a bit 3 steps forward, 2 steps back when it comes to health equity, and it's a dance that we continue to embrace and we continue to take steps forward in, but it's not moving at the pace that we all want it to move. So I will say that change takes time, and with persistence and tenacity, we will arrive at a day and a time and a place in our country where all people around the world have the chance for optimal health. We will get there. But you are in for a real treat. You're going to hear from some of our leaders. You're going to experience a riveting talk from our award winner, and you're going to be inspired by a moderated panel moderated by our dear Dr. Reed Tuckson, who I just saw slip into the room. Come on forward. You have a seat right here once you get mic'd up. You were in for a real treat. So thank you again for taking the time out of your day to be here with us. We have over 100 people joining us in our live stream, and we have about 60 people in the room. Some people will be coming in a little late because there's a lot going on in DC today. A lot. And so to get us started, let me introduce Dr. Tanette Krause-Wood. She is the current president of the American College of Preventive Medicine, and she is a professor of medicine and epidemiology. She's an associate provost for the health sciences and the senior associate dean for faculty affairs at Tulane University School of Medicine. She has a very distinguished career, and her research interests are focused on clinical outcomes, healthcare processes for patients with chronic conditions, such as hypertension and diabetes. And she has another whole range of research interests that range from medication adherence in older patients with hypertension, adherence to physical activity recommendations, and the list goes on. So without further ado, I'm going to introduce Dr. Krause-Wood to get us started, former board president of the American Board of Preventive Medicine, fellow of the American College of Preventive Medicine, and current president of ACPM, Dr. Krause-Wood.
Height challenge. Thank you, Donna, for a very kind introduction and a very warm welcome to everyone. Many thanks to all of the staff at ACPM who did such amazing work pulling this event together and implementing it so well. So thanks to all of you, but a special and a heartfelt thanks for you attending today. And as Donna mentioned, we have a wonderful program that I think that you all will learn from, but also enjoy as well. You know, in preparing comments for today and thinking about this event and reflecting more or less on Dr. Blumenthal, as I called him. I met him as a resident in Deep South. We call him Dr. Blumenthal. Thinking about his work, came across a quote from Albert Einstein. And the quote was, "Strive not to be of success, but to be of value." And as we honor him today and we reflect on the work that he has done, it is very clear that he strove to be of value. It was also a great success, but he strove to be of value. In May of 2017, Dr. Daniel S. Blumenthal was the president of the American College of Preventive Medicine. He also had a very important responsibility as he presided over the annual Preventive Medicine Conference, where he selected plenary and keynote speakers and essentially defined the theme for the conference based on his experience and programmatic expertise looking at social determinants of health. And the theme that he and his team chose was a focus solely on disparities in health and healthcare. Now, this topic was being thrown around in the medical world at the time, but he was truly ahead of his time in focusing an entire conference on this issue. In 2019, Dan died suddenly. It was before the COVID-19 pandemic, before the social unrest that burst out nationally after the death of George Floyd, and before we began a sincere and focused effort looking at social determinants, social justice, and the impact this had on health. You know that Dan would have wanted to be a part of the discussions. He would have wanted to be mostly part of the solution. Dr. Stephanie Zaza, who was the president of ACPM at the time of his death, knew that it was important that we honor the legacy of Dr. Daniel S. Blumenthal. We wanted to continue to educate the profession, colleagues throughout health and the medical enterprise, and the decision makers that can focus on issues around social determinants and social justice. This is where the idea for the annual Daniel S. Blumenthal Lecture on Health Equity and Social Justice was born. Many of the members and guests tonight have their own personal stories about Dr. Blumenthal, and of course I have my own. When I met him, I was a resident. He was larger than life. He was a quiet and brilliant man, and you could tell from the words he spoke and the way he carried himself, he was passionate about the field of preventive medicine, public health, and the things that he knew drove the inequities that he was seeing in his work and in his practice. Most people, when you've asked them, what do you remember about Dr. Blumenthal, how would you describe him? The words mentor, visionary, connector, optimist come through. Certainly, he was all of these things and many more. He set the tone not only for the conference in 2017, but he set the tone for the college for us to move forward on a very important journey to address health disparities, social determinants, and to move our nation and our communities forward. As president of ACPM, I also want to share that in 2020, the college, we looked inward. We looked at our history, the things that we had invested in, the initiatives that we started, the truth-telling that we had to do, and our own soul-searching. We also looked outward at the organization to see where the challenges were and the opportunities for the American College of Preventive Medicine to have a real role in addressing social injustice and addressing the social determinants of health. This lectureship is just one of the many important parts of our journey to make a difference in this nation and to make a difference beyond. As Donna already mentioned, we have just a star-studded program this evening. We're going to begin with Dr. Blumenthal's wife, Dr. Marjorie Spears, to share some insights. We're also going to have some comments that Dr. Satcher shared with us, and we're also going to have an outstanding expert panelist share their insights and their visions and help us really connect these dots on where we are with the current challenges, but mostly focusing on where are our next steps in driving solutions. So let's go ahead and begin. Dr. Marjorie Spears, the wife of Dr. Blumenthal, served as the Deputy Associate Director for Science at the Centers for Disease Control and Prevention, the Executive Director of the National Bioethics Advisory Commission, President and CEO of the Association for the Accreditation of Human Research Protection Programs, and the Executive Director of Clinical Research Pathways, a nonprofit that worked to increase minority representation in clinical trials. No surprise that she and Dan were completely aligned in their passion for science, for representation, and social justice. As his wife, as his soulmate, please welcome Dr. Marjorie Spears to share a few insights.
Well, hello. It's good to be here again. Another year has passed, and I'm very pleased to be part of the annual award and lecture in honor of my husband. I want to thank the American College of Preventive Medicine for hosting this event, and for, I had heard even mentioned it at your annual conference this year, so it's really a wonderful thing that you do. And I think what Dan would say is it's wonderful, not because you're honoring him, but you're keeping the focus on equity and social justice. And so I thought that what I would talk to you about is not so much Dan's history. You're going to hear a little bit about that from Daniel Dawes this year. But what I have been asked since the beginning of COVID in January of 2020 till now is, well, what do you think Dan would have thought about it? Well, I don't really know, okay, right? You can't ask the dead what they think about things. But as you heard, we did share a lot in common. We talked a lot at home about health, public health, and my work and his work. And so when I think about COVID-19 and what it means, I think that when you look at it, the effect that COVID-19 had on minority populations was extreme and extensive. And so I just want to iterate some of those effects. I'm sure everyone in the room is familiar with them. But, you know, among Blacks and Hispanics, Latinos, more death, higher death rate, more hospitalizations, more severe disease. And what we haven't talked a lot about, I think, in public health to the degree that we should, if some of those higher rates that we see are due to what we know is affects minorities: obesity, hypertension, diabetes, not good access to health care. When this epidemic started in Georgia, it was in the southwestern part of the state, in a county where Georgia had closed a hospital. Patients in that area didn't have access to health care. Since the time of our meeting last year in 2020, we have seen other negative effects of COVID-19, how it affected essential workers, who are often minorities, how it affected school children, kids who couldn't go to school. Private schools opened, public schools did not in some states, in some counties. Some kids did not have access to laptops and couldn't really zoom into classes, or they had no one at home to watch over them to make sure that they were doing their homework and paying attention. Minorities were more affected by that than other students. So I think Dan would have said we have to keep our focus, continue to focus on equity and social justice, that when this pandemic hit us, even though, another fact was, you know, even though we managed, and I say we, I was part of this effort, to get minorities recruited into the vaccine trials. And that was not easy because it wasn't planned in those protocols initially. We did not find minority communities necessarily receptive to receiving the vaccines, that the effects of COVID on minority communities was widespread. And so when we think about disease and health, we have to think broadly. We have to think about housing and education and social support and all the other things that lead to good health and quality of life. And I think that's what Dan would have talked about and tried to push for as much as he could. The last thing that I want to mention about Dan is that there was a book that was published, that was actually published in May of this year. It was a project that he was working on with 3 of his colleagues at Morehouse School of Medicine, Ron Braithwaite, Tabia Akintobi, and Mary Langley, where they wrote a book on community approaches in preventive medicine, and the book is called The Morehouse Model, How One School of Medicine Revolutionized Community Engagement and Health Equity. He was working on those chapters the day of his death. So he continues to be with us. I don't know why I'm so upset. But anyway, he is always going to, I think, be with us in some form. So I thank you again, and let's continue with the program.
Thank you, Dr. Spears. Heartfelt comments and sharing of insights, and we miss Dan. We know that you do as well, and we're grateful for the legacy that he has left us. Your comments, though, are an absolute perfect segue into our featured presentation today and announcing our second annual Dr. Daniel S. Blumenthal Lectureship in Health Equity and Social Justice Award, and to introduce today's keynote speaker and awardee, Professor Daniel E. Dawes, Juris Doctor. Professor Dawes is a widely respected healthcare and public health leader, health policy expert, educator, and researcher who serves as executive director of the Satcher Health Leadership Institute at Morehouse School of Medicine, and a professor of health law, policy, and management. He is the author of 2 groundbreaking books, 150 Years of Obamacare and The Political Determinants of Health, both published by Johns Hopkins University Press. Among his many achievements, he was an instrumental figure in developing and negotiating the Mental Health Parity Act, the Genetic Health Act, and other types of activities there. He also worked on the Affordable Care Act's health equity-focused provisions, among other landmark federal policies. He has served as a principal investigator for the nation's first health equity tracker, co-founder of the Health Equity Leadership and Exchange Network, also known as HELEN, co-principal investigator of the Health and Human Services National COVID-19 Resiliency Network. Professor Dawes is also an elected member of the National Academies of Medicine, an elected fellow of the New York Academy of Medicine. He serves as an advisor to the White House COVID-19 Health Equity Task Force, an appointed member of the CDC's Advisory Committee to the director and co-chair of the CDC's Health Equity Working Group, as well as the National Institutes of Health National Advisory Council for Nursing Research. I don't know how he has time to breathe. Nevertheless, Mr. Dawes is going to give us a compelling lecture today on health equity and social justice. We're very pleased that he is able to join us remotely, and if you will just join me in welcoming Professor Dawes, as well as congratulating him as this year's awardee.
Hello, everyone. I am so honored and humbled to be receiving this amazing opportunity of speaking before a room full of not only greatness, but before the women and men whose work, whose lessons learned, whose mentorship and whose missions have and continue to inspire me. This award today means so much to me on both a professional and personal level. You see, when I received the letter from Donna Grandy and Dr. Tanette Crucell-Wood, informing me that I'd been selected to receive the 2022 ACPM Dr. Daniel S. Blumenthal Award, I had to pinch myself twice. I had to first pinch myself because this incredible honor is coming from the American College of Preventive Medicine. Like everyone I know who works in the public health and health policy spaces, I, too, am very familiar with and impressed by your organization. And I've always been blown away by the more than 2,000 physicians who not only are proud members, but who really hold a hard line on the front lines and demand that our healthcare system put patients and their health and well-being first, including my own physician, Dr. Beverly Taylor, a proud member of the American College of Preventive Medicine. Everyone has heard it, An ounce of prevention is worth more than a pound of cure. As someone who has dedicated much of my time to looking upstream to address the health inequities that we see downstream, that proverb resonates with me and could not be truer today. And so I want to thank you all at ACPM for doing what I wish more providers did, for dedicating yourselves and the practice of your craft to prevention today to help prevent deleterious health consequences that will emerge downstream tomorrow. I also had to pinch myself a second time because of who this award is named after, the late, great Dr. Daniel S. Blumenthal. You know, I think everyone who knew him would agree that being a catalyst for real, meaningful, and just change that not only centered, but often demanded equity, even before it was popular or trendy to do so, quite literally ran through his veins until his unfortunate passing a few years ago. I, like everyone here today, not only am familiar with his incredible work, legacy, achievements, and unparalleled dedication to pushing for health equity, but I knew him. I considered him a mentor. I relished the moments we spent together at Morehouse School of Medicine, discussing health policy issues, strategizing about how to move the health equity strategy in Georgia, as well as the South and the nation as a whole. He was the first person 10 years ago, when I first joined Morehouse School of Medicine, who welcomed me and invited me to meet him and discuss how we could work together to protect and implement the 62 health equity provisions of the Affordable Care Act, and specifically how we could work together to expand Medicaid coverage in Georgia. He took me under his wings and he helped me navigate the precarious political waters here in the South. And he would check on me every so often to make sure that I didn't become discouraged for too long. In preparing for today, and when I reflected upon his numerous accomplishments, I thought about what he did before he came to my home at Morehouse School of Medicine. You see, even before he hit our campus at Morehouse, Dr. Blumenthal recognized that healthcare professionals held an enormous amount of potential to positively affect social change through their experiences working as a physician in a broken healthcare system. He witnessed firsthand how the broken parts hit and devastate some individuals harder than others on a very regular basis. This was especially true for our nation's most vulnerable, most marginalized, most underserved, and often the first to be overlooked, ignored, and forgotten. This epiphany happened for him in the late 1960s in Arkansas, when the negative health consequences of systemic racism and social injustice were thrust in his face. Rather than retreat, though, as he himself would often say, he soldiered on and harnessed his visceral contempt and disdain for inequity, injustice, unfairness, and systemic racism, and turned that into a momentum that created a wave of change. In fact, Dr. Blumenthal devoted almost 40 years of his life training a wide range of rising and current health and healthcare professionals about how to respectfully and properly care for and treat our nation's most under-resourced and disadvantaged populations. Through his teachings and his trainings, he did not only teach empathy and respect for diversity and difference, he demanded it, he instilled it, and to all who fell under his tutelage, I know that we are all better health leaders for it. Through his work and his example, Dr. Blumenthal laid the foundation upon which so many of today's policymakers and key public health policy, and health equity educators, stakeholders, and researchers position their work to eliminate health inequities and advance health equity and justice. I am no exception. Dr. Blumenthal's work and his courage to push the envelope toward racial and social justice, to improve health and wellness, inspires me every single day. And this is why. Because he used his influence as a physician to try to achieve the sort of needed change to prevent deleterious health outcomes that would emerge downstream. And he did so before anyone was even talking about health disparities among the uninsured, or DEI efforts, or the health impacts of structural racism and discrimination. Without recognizing it, really at that time, he sat in a position upstream and could foresee that without major systemic changes, there would be negative health consequences that would befall Black, low-income, and other minoritized individuals and communities later on downstream. This is why he and his legacy inspire me every single day, and why I am deeply humbled to be recognized with an award named after him, in his honor and in his legacy. And I hope that the work that I have been undertaking, work that is analyzed through the framework of the political determinants of health, would make him proud. I didn't have the chance to share this framework before he passed, but I want you all to know that his fingerprints are all over it. Today, I'm grateful to be given an opportunity to share this framework of the political determinants of health, and why this lens is so important if we are to ever move beyond merely nibbling at the edges of the problem of health inequities in our country. You see, this framework looks upstream in time to identify the root causes of the negative health and healthcare issues that float about downstream in real time today, and that will likely worsen without impactful change. Through this lens, it's evident that the political determinants of health give rise to the social determinants of health that are often discussed today. These latter determinants are widely credited with creating, sustaining, and even exacerbating the health inequities that to date we have not eliminated. Perhaps then it's time for all of us to look further upstream, further than the social determinants of health, and invest our time and energy in and on solutions that focus on the political determinants of health. I think that if we did this, we would see significant progress in our collective fight to achieve health equity and eliminate health inequities. When I think about the work that you all are engaged in, and the type of leadership I've witnessed at ACPM, one quote in particular always comes to mind for me. It's a quote that is often attributed to my fellow Nebraskan, Warren Buffett, but it's actually credited to the notable British philosopher Bertrand Russell. The quote says something along the lines of, "The chains of habit are too light to be felt until they are too heavy to be broken." Think about that for a moment. The chains of habit are too light to be felt until they are too heavy to be broken. What Mr. Russell, the Oracle of Omaha, and all of you have in common, quite frankly, is an innate understanding that the only way to truly accomplish lasting and meaningful change is through a commitment to moving outside of the status quo. And for that, I am so thankful to all of you for your tireless work to create and enact change, promote and concretize health equity and justice, and improve the conditions of our communities. To ensure success of these efforts, we cannot ignore the political determinants of health. Now, I know that we all know the long arc of history eventually bends towards justice. But as it bends, it can also wobble. Notwithstanding the fact that we have entered a new period in our health equity movement, according to recent articles published in the American Journal of Preventive Medicine, the British Medical Journal, and Health Affairs, among others, research is showing how little progress we are making in eliminating health inequities in America. Within healthcare and public health, we are awakening to the ways in which research has falsely looked at race as a biological attribute rather than a social construct over centuries, contributing to systems of racism in healthcare delivery, education, housing, transportation, employment, and public health. And at long last, medical, nursing, and public health science are declaring that race is not biological but that racism has profound consequences for health. To address this unfinished business of healthcare and move the dial of health equity in a meaningful manner, to a meaningful degree, it's going to take greater action from all of us, harnessing the power of collaboration with communities disproportionately affected. So why is this important? Well, here's why. 10 years after Dr. King died, Dr. Martin Luther King Jr., the United States government finally held its first ever congressional briefing, or rather hearing, to specifically address minority health and health disparities in the country. One of the most striking points from that congressional hearing and the ensuing report that came out of it was this, and I'm quoting, "Although a full commitment to equality has never characterized American health policy, serious questions arise whether the present partial commitments to equality in healthcare will be maintained." Well, while it's shocking to read the unequivocal acknowledgement that we've never experienced a full commitment to health equality in American health policy, what's even more concerning to me is that health equity leaders back in 1979 doubted that even the limited gains they had achieved would be maintained into the future. Unfortunately, they were right. With our demographic shifts, decreases in life expectancy, and poor health status, we can no longer afford to embrace a partial commitment to equality in healthcare or tolerate the dearth of programs, practices, and policies addressing health inequalities. Now, I know that progress has been made in the fight to reduce racial and ethnic health inequities and expand the conversation about their root causes. Today, the social determinants of health are widely recognized as contributing and even determining as much and even more to the health and well-being of individuals than medical care has, right? Additionally, as greater attention is paid to the social determinants of health, the deleterious consequences of racism and racial bias simply cannot be, and increasingly are no longer being ignored, thankfully, right? But it's also clear that we still have so much more to do and so much further to go to address the fundamental causes and the instigators of health inequities in the United States and around the world. So, what gives rise to the social determinants of health? And more importantly, why have they disproportionately and detrimentally affected the communities that I've just mentioned for so long? Why do they continue to do so, and what can we do as a community of health equity champions to mitigate and eliminate their negative impacts? You see, in my mind, the answer is clear, very clear. We have to look further upstream and focus on the political determinants of health that provide the momentum and currents that have created and sustained the social determinants of health. And as we seek to eliminate the health inequities that sit downstream, we must ensure that we keep structural racism at the forefront of our research, of our analyses and practice, so that the impact of explicit and implicit racial bias does not get watered down. From a political determinants of health lens, the principal roots of inequity began to enroot, and the political determinants of health inequities began to incubate in America in 1641, when the commercial interests, wanting to sustain their business model of slavery, worked with the policymakers to codify this evil institution into the body of liberty's law. It is here where our moral compass strayed from its true north, through the aid of politics and policy. And while strategies and policies have changed over time, moving from explicitly racist policies to what are supposedly facially neutral policies, the impact is the same. And like so, the political determinants girded by racism and other forms of discrimination continue to shape America in many other ways, Structurally, the Highway Act of 1956, which authorized the construction of a 41,000-mile network of interstate highways that would span the nation, routed highways directly and purposely through black and brown communities, sparing white, affluent, and middle-class neighborhoods. We saw the placement of railroad tracks and disproportionate placement of bus depots in communities of color by acts of policy. In some instances, the government even took homes by eminent domain with the passage of the Housing Act, which displaced over 500,000 African Americans, Latinos, and Asian Americans. Tearing through the heart of these vibrant communities, this massive effort came during a time when courts nationwide were striking down traditional forms of racial segregation, and during a time when racial rezoning was on the rise, stopping all efforts dead in their tracks. Today, we can more easily see the effects that these infrastructure have on the health of racial and ethnic minority communities. Higher rates of asthma, owing to the smog and polluted air they are forced to breathe in. Higher rates of diabetes, cancer, heart disease, lupus, etc., owing to the structural conditions these communities find themselves in. But as we think about these social determinants of health, we need to think about how they came to be in the first place. Similarly, the poverty tax has been and continues to be used as a vehicle to exploit low-income households, disguised through sophisticated methods, such as higher interest rates on their loans and mortgages, higher homeowners and auto insurance costs for those living in neighborhoods with a median income of $30,000 or less, and in some parts of the country, even higher costs for groceries, according to a recent Brookings Institute study, which, quite frankly, leads us down a whole other path of food deserts, hospital and pharmacy deserts. These political determinants of health, you see, inequitably distribute social, medical, and other determinants, and they create the structural barriers to equity for population groups who have lacked power and privilege for too long in our country. I define the political determinants of health as involving the systematic process of structuring relationships, distributing resources, and administering power, operating simultaneously in ways that mutually reinforce or influence one another to shape opportunities that either advance or hinder health equity. In the wake of this COVID-19 pandemic, we've seen a repeat of a historical tragedy during a modern era, which we've come to believe is more evolved and learned from any previous point or time in our history. When does it end? When do we finally allow history to remain history and stop it from continuing to repeat itself? Well, today I am very optimistic because by my count, we have entered a remarkable period in U.S. history, the Fourth Great Awakening for health equity-focused policy action in America. These awakenings include, first, Abraham Lincoln's policy to address the social determinants of health needs and provide health care to newly freed people and poor white people. The second, the desegregation of hospitals in the 1960s, owing to Medicare and Medicaid legislation, the Civil Rights Act, and of course other important policies. The third period involved the passage of public policies addressing minority health and health disparities, which included the Affordable Care Act. And of course, the current moment today, under the Biden-Harris administration, which for the first time in U.S. history is harnessing the powerful levers of the federal government to advance health equity and address the upstream determinants of health inequities. It's not lost on me that we are discussing these issues today against the backdrop of all of the racial injustices we hear about nearly every week. The COVID-19 pandemic, which we hear about every day, and the efforts at all levels of government to stall equity-focused policies, which we hear about almost every hour. All three of these moments have a disproportionate and extremely harmful impact on the health and lives of indigenous populations, as well as African Americans, Latinos, and Asian Americans, and other people of color. They also, in very real and direct ways, serve to the detriment of our collective efforts to achieve health equity in this country. The late, great Senator Paul Wellstone said this many times before, and I'm going to say it again. Policies reflect the current values of their time. Policies reflect the current values of their time. So what does this tell us about the time period that we're all in today? Well, I have come to realize that the complicated origins of events that occurred in the past really do explain the complicated present times we live in today. That each time health equity champions like yourselves realized progress in the movement to advance health equity and justice in the United States, they were followed by periods of retrenchment, backlash, and regressive devolution. And so these three moments, while they are major concerns with which we all contend now, are rooted in the political determinants of health that I just highlighted. Determinants which started so far upstream, and here we are today, so far downstream, wading in these troubled waters, trying to figure out what to do. Over the last 233 years, this nation and its leaders have tried. They've tried to integrate principles of equality and equity into laws and policies that directly impact all of us. Now, I'll be the first to admit there have been some successes, but quite frankly, far too few have passed and been allowed to advance health equity in America. Given all that we have witnessed these last few years, where do we, as a community, go from here? Well, there is no single answer, and righting the wrongs that have created and worsened the health inequities we see today is going to take time. But if we want to all realize a full commitment to health equity and live in a just and equitable tomorrow, then we have to address this now. And so it is my hope that my remarks today are received and interpreted exactly as they are intended, as a multi-pronged call to action to, 1, advance the research and discussion about structural racism and implicit racial bias as a causal factor of health inequities. 2nd, to expand the focus to hone in on the racial and ethnic health inequity crisis that has and continues to unfold right in front of us. And 3rd, to focus upstream on the political determinants of health, to then create a more informed dialogue about the origins of and the solutions to the social determinants of health that have continued to create, sustain, and exacerbate health inequities. I want to thank you all so much for the privilege of your time and attention today, and for bestowing upon me the 2022 Dr. Daniel S. Blumenthal Award. I dedicate this award today to all health equity champions and trailblazers who have advocated for a more healthy, equitable, and inclusive society, without whom we would not be here today. Your fingerprints are all over this award. I also want to thank you all at the American College of Preventive Medicine for the courageous and humbling work that you've all been doing to protect and elevate the health of all of our communities. All of them, especially during this dark and historical moment, during this endemic, in fact, and of course, for your remarkable leadership in working assiduously to address the root causes of health inequities. As we move into the future, it's worth remembering that the movement to advance health equity is not for the faint of heart. And as my dear friend and mentor, Dr. David Satcher, has consistently reminded me, he stated, especially now more than ever, what we need are leaders who care enough, know enough, have the courage to do enough, and who will persevere until the job is done. I am so hopeful about our future because I know we have such leaders and champions represented at the American College of Preventive Medicine. Thank you all so much again for this honor.
Well, wasn't that great by Mr. Dawes? It's a pity we couldn't get him here live, but I think it was good for us to have him give that presentation. I'm sure, as you heard him say, that Dr. Blumenthal was a mentor to many, including him. And there are a couple of things I want to touch on, and I know we will have a panel and a number of people who will be joining that panel and discussing this. But as I think about what Mr. Dawes said, and I've met him before, you know, we talk about, and we sometimes may forget, but we as physicians can affect social change. Maybe it takes a lawyer to remind us about that sometimes. I also want to touch on Dr. Daniel Blumenthal. We've heard a lot about him, and his wife, Dr. Spears, talked about him. I first met him about 30 years ago when I, too, was a young resident, as Dr. Krauselwood said. And he was always somebody who was a mentor. We've heard about that. But I think the thing about him I will always remember is his gentleness. There was a gentleness about Dan that you couldn't forget, and he was a kind soul. And that meant a lot to me as a young person. And it meant a lot to me when in Portland, Oregon, in 2017, he was the president. And he and I talked about becoming the treasurer, and I did become the treasurer under his watch as president. And in talking to Dr. Spears earlier, before this meeting, I didn't know that we had another connection. I am from Guyana, and Dr. Blumenthal and Dr. Spears went to Guyana in 1996, she told me, to give a talk there on cancer at the University of Guyana. And I've just spent the last 5 weeks there in Guyana looking to do some work with the government, with the university, and it's nice to know of this connection too. I'll now introduce the moderator for the session, Dr. Reed Tuckson. He's Managing Director of Tuckson Health Connections, a recognized leader in his field. Dr. Tuckson has been appointed to leadership roles at the National Institute of Health, National Academy of Medicine, numerous federal advisory committees, and since he's come up in a hurry, I won't go through the rest of it, but I will say, no. He is a graduate of Howard University, just up the road, as it were, Georgetown University School of Medicine, and the Hospital of the University of Pennsylvania's General Internal Medicine Residency and Fellowship Program. And he was also a Robert Wood Johnson Foundation clinical scholar studying at the Wharton School of Business. I know that he's an inspirational leader. I've followed his work, and I was here last year. I love the way he introduced people when he said, "You may not know." I was going to do that here, but the rest of you may not have been in on that. And he is, of course, the former boss of our CEO when he was when they were both at the American Medical Association. So I'll turn it over to Dr. Tuckson, and he may not know, but he's got to introduce the panelists, and I'm deeply honored to meet and work with him. Dr.
So
Tuckson.
funny.
Thank you.
Oh, okay. A little scene change. Well, I'll get started. I think they'll get the hum out of the system some kind of way. And I had the great privilege of receiving that lovely award from Dr. Spears, and it's still a wonderful, wonderful treasure for me. So great to be in your company again. This is a transitional moment in our industry. It's a transitional moment in health and medical care. And we'll have to make sure that we take good advantage of it. I think Daniel Dawes was very correct in the sense of moving upstream. And what he's done now is to make us go like way upstream. I mean, we were moving upstream from clinical care, treating disease, preventing death, managing chronic illness, moving upstream to the social determinant. Now we got to take out machetes, hatchets and clear the woods to get upstream enough to be able to grapple with the root causes of the root causes. I'm from the South, so I think it's root, but I can't, it's hard to get that out. The issues of inequity, distrust, misinformation, social determinants of disease, all of them form together into this brew that leads us to death and misery. We've got to overcome fundamental key contextual forces. And I think Dan Dawes really got a good job of that. But let's just realize what we're up against with this tribalism, this toxic sense of me against thee. And the tribes are getting smaller and smaller, aren't they? They're getting so refined down so that to the point where I don't even know where, you don't even know where you belong anymore. It's so small. And no matter what, anything that is other than you is a problem. And power is being exerted across all of those different domains. But we also have to take advantage of key contextual forces that are in our favor. I think that we cannot deny the importance of the change from fee-for-service to value-based reimbursement and what that really means. And it really does mean that now that reimbursement, no longer on piecework, but on outcomes, combined with the enormous power of data and analytics to be able to identify the person at risk early so that we can then harness the full array of comprehensive forces necessary to deal with them so they don't tip into sick, but in fact stay well. And so that, of course, takes us to these social determinants in many ways and so many other elements that will give us a chance to have that person maximize the full extent of their possibilities for health. This, of course, then, as we deal with those forces in the society, gives us a chance for new partnerships. And so going upstream for the clinicians means running into, I hope, the clinical delivery system, who's coming downstream. So we kind of come together, and we'll start meeting each other somewhere in the middle. And that's the real moment, I think, for leadership for ACPM with others, to be in the middle of that conversation and make all of that happen. And so I'm excited by that, but I'm really excited by these panelists. And let me ask them to come on up, each of them, please, just together. We're all going to be up here because you're so lovely and wonderful looking, and everyone wants to see you. And Dr. Julie Morita, if you would, in fact, first, Julie, be right here and ready to go, because as we just heard, you may not know this, but you are a physician who is the Executive Vice President of the Robert Wood Johnson Foundation, where you oversee all program, policy, research, and communication activities. But 20 years before doing this, when you were very, very, very young, you were in the leadership in the Chicago Department of Public Health. And while commissioner, led the development and implementation of Healthy Chicago 2.0, a 4-year health improvement plan focused on achieving health equity by addressing the conditions in which people live, learn, work, and play. And so she's been at this a minute, and I'm really eager now to ask you to give us your reflection. I do want to also mention before you do that, though, that I was impressed that you were on the Biden Transition COVID-19 Advisory Board, and we really want to thank you for getting it right. So with that, thoughts on the topic?
So maybe what I will do is, well, first of all, I want to stop and to thank the ACPM for inviting me to be here today, to really be able to be part of the celebration for Dr. Blumenthal, to celebrate Professor Dawes as well. I mean, the work that they have done is really trailblazing, as Daniel said, as it relates to what RWJF is really focusing on. So what I wanted to do a little bit is really talk about, maybe pause for a moment so we get rid of the echo. Is to talk a little bit about what Robert Wood Johnson Foundation actually does, because some of you may not be familiar with it. But the foundation is actually the largest national philanthropy that has focused solely on health and health equity. And we've been doing this for 50 years. And for the first 40 years we were working, we really focused on health and healthcare delivery. But what's happened over the past 10 years or so, since 2014, we actually launched a vision of a culture of health. So some of you may be familiar with that because you hear about it on NPR. They talk about culture of health. That is Robert Wood Johnson Foundation. And that culture of health is really about really creating the conditions for everyone in America to have a fair and just opportunity for health and well-being, and really grounded in health equity from the very beginning. Our founder, Robert Wood Johnson II, actually really focused on always looking at healthcare, providing healthcare services, improving health for those who have the greatest need. And so since 50 years ago, we have really been focused on that kind of work. We really want to focus on not just the delivery of healthcare services, but also about creating the conditions within the in the communities. So these social determinants of health, that Dr. Spears mentioned and also that Daniel mentioned as well. And we've been looking at trying to improve those conditions for everyone, no matter who they are, where they live, or how much money they actually have, really creating those conditions overall. In 2014, when we launched our vision of a culture of health, health equity was always a real focus and central to our vision. What's happened over the past couple of years with the COVID pandemic, with the racial uprisings in response to the violent death and murder of George Floyd, the foundation has increasingly focused on structural racism as a barrier to health, recognizing that while we're focusing on systemic and structural barriers to health overall, there's no greater barrier than structural racism itself. And so we have become much more explicit and intentional in that focus in our work overall. I think COVID, as I mentioned, really made clear some of the impact of these political determinants that Daniel mentioned earlier today, in terms of the policies that are put in place that really led to our Black and brown communities being more significantly impacted overall in terms of poor health outcome, more hospitalization, more death, due to problems like inability to work from home, lack of paid leave, lack of insurance, lack of access to healthcare services. So it's these political determinants of health that really led to these health inequities that we saw play out so dramatically through the pandemic itself. And so as a result of that, the foundation is really doubling down on this commitment to the communities who are most affected and really focusing explicitly on structural racism as a barrier to health. The foundation itself, the question is, how is it that the foundation actually does that? We actually focus on doing a number of things. So we make grants. We distribute about $650 million a year to support improving health overall within the nation. We fund research, really exploring what the connection is between structural racism and health overall. We also are looking at challenging conventional methods of research and assumptions, so moving forward to be doing better research overall. We're also supporting the development and implementation of these policies, these political determinants of health, at the state, at the federal, and at the local level. So we are supporting this work as we move forward. We're also supporting strategic communications to dispel misinformation, to amplify solutions, and also to change mindsets about who's deserving of good health and well-being. The foundation has never worked alone. We've always worked in partnership with others. And as we look forward to the future, we know that we cannot do this work alone, that it is too big of a problem to do this by ourselves. And so we're fortunate to have ACPM, the AMA, Change Lab Solutions, Morehouse, as partners as we do this work. And so I'm really pleased to have this opportunity to be here with you today as we consider you strong partners of ours as we move forward with trying to build this culture of health.
Thank you, Julie. Let me ask you one quick question, which is an impossible question to answer. If we're going to start to take what Daniel said and what you've said in terms of the politics of this, how far into that set of weeds are we planning or willing to go? Are we talking about vetting candidates? Are we talking about giving position papers to candidates? And also, are we talking about trying to foster conversations with people who think differently than we do? Is this going to be where we arm our side to beat up on their side, or are we trying to change the political equation? As I said, it's an impossible question.
Yeah, thank you so much for that very easy question. There's so much that I could actually say about that, because I think one of the things that we've really focused on over the past few years is really learning about the community power. I mean, I think we've talked a lot about community engagement and community voice and lifting it all up, but it's really not a matter of just engaging with community. It's really helping community to have the power to raise their voices, to talk about their conditions, to talk about the challenges they have, and also to enable them, empower them to be able to actually lead the solution development. And we saw some of that play out during the pandemic. And I think I was so fortunate to be asked to be part of the COVID task force. And that was one of the mantras that I had was, it's not just about engaging with community to tell them how they should fix things. It's really about bringing community into the solution development themselves. And so that is something, because what we ultimately want is for community voice and communities to be involved in policy change. So we have some good examples of work that we're supporting in housing, where we've supported community power groups to actually be able to really move the needle on affordable housing. And I think these are the kinds of things that we can actually do by supporting power. The other thing, though, I have to say is that for decades, the foundation had said we're nonpartisan, that we were going to walk this line so that we can engage with both sides of the aisle and really be able to advocate for policies that appeal to all. And we do believe that that is really important, that we can't do this alone. We can't just be entirely working with the left on some of the issues that we find really, really important. So how is it that we get to the point where we can really address shared values, which I think are really there on both sides of the aisles, is really engaging with both sides of the aisle at the value level, because I think there is commonality. And so we're really striving to see how it is that we can lift up these policies, which are pretty left-leaning. Our policies that we support are really, really left-leaning. How is it that we engage with the other side of the aisle to help them to really understand what we're talking about and helping them to understand that we can really move together and we will be a better place, a better country overall if we really work together?
You can see why I wasn't afraid to ask her that question. George Rust, you may not realize this, but you are usually found as a professor at the Florida State University College of Medicine in Tallahassee. I hope everything is okay.
Absolutely.
Where you direct also the Center for Medicine and Public Health. You serve as medical executive director for the Leon County Health Department and 5 surrounding rural county public health departments. Thank God for you. Thank God for you. Board certified in both family practice and preventive medicine. You've taught for 24 years on the faculty at the Morehouse School of Medicine, where you were founding director of the National Center for Primary Care. And in 2017, Dr. Dan Blumenthal presented you with the ACPM President's Award for your contributions on health equity. Congratulations on that.
Thank you.
What are your thoughts, sir?
Well, first, let me just say it was an honor to know Dan personally, and I would just echo all the things that have been said about him, the gentleness and kindness. I appreciated that comment. The one I would add to that is humility. Dan had that ability to be passionate and forceful without undermining your force. And I'd say that in addition to all of the programs that he built and the scholarly leadership that he provided, one of his commitments was to developing people. And I'd say that was perhaps his biggest commitment, was the generation of leaders that he helped train and nurture and cultivate. That model of community health development maybe was in his blood, but he had that ability to make sure that he wasn't trying to be the voice for other people, but he was trying to make sure that authentic voices were being heard. So a couple of thoughts. Daniel Dawes is also a friend, and we have lovely conversations about this sort of thing. So let me offer 3 thoughts, if I can, real quickly. One is that we got to believe. And what I mean by that is we have to have an affirmative expectation that health equity is the only acceptable outcome and that we're going to get there. You look at some of our great leaders in history. I think about Desmond Tutu saying that we have already won 20 years before apartheid ended, and speaking it into being, expecting that outcome, I think is part of what we need to do. And what that means also for us in the weeds is we have to have surveillance systems that are regularly measuring outcomes. If we're working upstream, if we're working broadly on social determinants, we can sometimes get lost from the outcomes that we're trying to move the needle on. And so we need to have surveillance systems, rapid cycle data feedback loops that tell us whether or not it's working, whether we're moving the needle or not. And as Tom Peters would say, we don't have time for ready, aim, fire. It's fire, aim, fire, aim, fire, aim, until we get on target and prove that we can make a difference. We've done research to demonstrate that there are communities in the country that have eliminated disparities in certain areas. We've got to learn from those folks to figure out how they did that. Disparities are not inevitable. Equity is achievable. And we did some projections recently looking at when we would eliminate the black-white infant mortality rate in each state across the country if we continued on our current trajectories. And some states will do it in my lifetime, hopefully, knock on wood. But some states won't get there for another 100 years. Well, let's hold each other accountable to getting to that outcome, because it is doable. The second thing is, aside from we got to believe, I'd say we got to work together. And part of that is across racial ethnic groups, that glorious rainbow coalition across gender marginalized communities, finding those commonalities to work together toward equity as that positive outcome. But working together in other ways in which we tend to say this, not that. Prevention, not cure. Upstream, not downstream. I walk around all day long doing this. You know, we need each other desperately. Those frontline clinicians are so valuable when it comes to having a just this week story to tell policymakers when you're trying to influence outcomes. A small community health center, a migrant community health center where I started my career in Groveland, Florida, was the biggest employer in that community and had tremendous potential to affect the social determinants of health in those neighborhoods by creating career tracks for people who could be hired from neighborhoods and then trained and grown into careers. We also had a consumer majority board where migrant farm workers were managing a $10 million healthcare organization at the time in a highly regulated environment and learning leadership skills and financial skills and so forth, and became the next generation of leaders for that community. So upstream, downstream, public health, medical care, that's what I want to say to everybody. And the third thing I guess I'd say, and this is relevant to Dan's career, Dan Blumenthal's career as well, is that some of you are probably too polite to have noticed, but I'm a white guy.
Oh, really?
Truth be told, I'm a cisgender, not very good Christian white male. And my message to my people would be, get in the game. That I grew up in a semi-dysfunctional family, and so I understand about walking on eggshells, of trying not to deal with the elephant in the room of abuse or of dysfunction or of anger or rage. We can't afford to do that. This is not somebody else's problem. This is not for minoritized communities to fight this battle by themselves. And so whatever power or privilege we have, we've got to use that. There are some organizations that are so white and so male in their norms and their culture and their power that nobody but us is going to be able to advocate for equity. There are other organizations that are more diverse where we can amplify voices of people who do have authentic lived experience and whose voices need to be heard. And sometimes I just need to say, you know, we ought to listen to them. They make sense. They're right. And amplify those voices. And then some of us get to work at places like Morehouse School of Medicine, where I spent a quarter century, where I really get to listen more than I talk, which is rare for me, as you know. Where I get to learn more than I teach and to serve more than I lead. And Dan gave us that model, and I tried to emulate some of that while I was there.
Well, you know, this is, you know, we joked about this point about you being a white male, but this is very serious because I think that the more I look at how I react being on, you know, too many town hall presentations and so forth with well-meaning brothers and sisters who are white, is to say, look, you know, black folks are tired of trying to explain to you what this is like. And by the way, black folks can't convince white people to stop being racist. That's going to have to come from y'all's family. That's right. And I think this is a very serious point. And it sort of comes back to why I was sort of, provoking Julie a minute ago in the sense of the politics. If all of our politics are tribal, we stay where we are forever. And I wonder whether you think that there are places, inroads for well-meaning people who are white, who have common shared human values, to have those conversations with their friends who may actually identify as being Republican or libertarian or whatever. Is this possible?
I think so.
You said we have to believe.
We have to believe. I think there were moments at Morehouse when I played that role, walk across to Emory and say, come here, Sparky, let me talk to you about this, about what's happening here. The analogy I would give is that as a primary care physician, I've always considered it an honor when I'm working with a patient and we have to discover together the diagnosis of cancer. And it may be my role then to facilitate a conversation between that patient and their family where they all knew what was going on but were afraid to talk about it. And they each say the word cancer out loud in front of each other. Mm-hmm. Some institutions that are historically white and have persisted in their historical whiteness have a hard time saying the word racism, have a hard time addressing inequalities. And so sometimes it will be specifically to say, we need to talk about this word together. Sometimes it will be simply being the person in the room who can ask the naive question. Why is it that our women are getting paid 30% less than our men? And why is it that we claim to be a diverse organization, but the diversity is all on the front desk and among the nurses' aides, but the farther up the chain I go, I get to white women, and then when I go to the C-suite, it's white men, or the governing board. And so being able to, a phrase that I routinely use in that context is vertically proportionate diversity. And encouraging organizations to audit themselves on that. How are you doing across all the levels of power of controlling budgets and hiring and making policy decisions? How are you doing on making sure that the people, the communities that we serve, that we are just as diverse as them? And that in areas where there are smaller minorities, we know in survey methodology that we oversample minorities. Where are the trans voices in our organization? How do we make sure that we're getting authentic representation of those voices at the power levels where they'll really be heard and make the difference?
That is a very sophisticated point. Thank you for making it. Well, Jesse Ehrenfeld, you don't know it, but you are the president-elect of the AMA, my friend. Congratulations.
Yeah. Thank you. Thank you.
But when you're not doing that, you're somehow passing gas, doing anesthesiology, you're doing a clinical practice, you're doing research, you're doing health policy, you're teaching at Vanderbilt, and then somehow you're directing a $650 million statewide health philanthropy. So, good on you, brother. You, a combat veteran, deployed to Afghanistan, but for 20 years you have advocated on behalf of the lesbian, gay, bisexual, transgender, and queer community. Thank you for doing that. And you and your husband have a son named Ethan. And as you look at all these multiplicity of your roles, how do you focus in on this issue of equity?
Well, let me start by thanking ACPM and you all for having me here today. It's a pleasure to be here to celebrate the life and legacy of Dr. Blumenthal and to highlight some of the successes and challenges as we collectively try to partner together to create a more equitable health system. You got it right. I'm president-elect of the AMA. That's a new role for me at the AMA. But what I'm not new to is trying to do the hard work of achieving optimal health for all. I am an anesthesiologist, and yesterday morning, I got up at 5:45, got dressed. My son Ethan got up a little bit later, got him going. And I got to the hospital. I walked in to see my first patient, and she was a 72-year-old black woman who has newly diagnosed advanced breast cancer. It has spread to her lungs. She is likely going to have a tragic, preventable outcome, not because of anything that she did wrong, but because our healthcare system has failed her. And she may have had healthcare coverage, but the ever-present inequities in our society, the structural barriers to actually receiving care that we know could have added years to her life, created a situation that is all too common that I see every day I'm taking care of patients for people of color, for poor people, for people from rural communities, for LGBTQ people, for women, for people with differing abilities. And to advance the goals of health equity, the AMA has doubled down. And we have said we have to have an aggressive effort to eliminate long-standing inequities within our healthcare system caused by structural racism, to remove those barriers to care, and to improve outcomes for historically marginalized communities. Now, we're working towards equity in every area. Our policy compendium through our House of Delegates policymaking, our legislative proposals that we work on here in DC, the programs that we support with our partner organizations, including ACPM and others, our work to promote diversity within the profession. In 2019, we took a really important step to create our new Center for Health Equity that really is a hub for our equity work. And I know that Dr. Aletha Maybank, who is the leader of that hub, was with you all last year when this award was inaugurated. We recently launched a medical justice and advocacy fellowship in partnership with the Morehouse School of Medicine that we're incredibly proud of. And in 2021, we publicly acknowledged in our plan to embed racial justice and advance health equity, which is a multi-year plan, where we went wrong. And when you have 175 years of history, there are a lot of places where we went wrong. And to acknowledge those missteps, to acknowledge the opportunities that were lost, and to chart a pathway to the future is really where this center and the leadership and hopefully my presidency will be able to drive towards. And when I think about what's in that strategy and that plan, a core component is to push upstream to address all of the determinants of health and the root causes. And for almost a decade, I led an LGBT health program at a major academic center, a program which last week, like about a dozen other programs around the country, came under vicious attack. Public threats of violence on national television. When I think about how do we erase barriers to care in the LGBTQ community, we've got to push upstream, like our keynote awardee talked about tonight, to look at the larger legal and political climate. It's the only way we're going to get there, and it is challenging, particularly when we look at what we're up against. But we know that if we don't undertake that, the challenges that trace all the way back to childhood, to school, the home, that lead to these preventable outcomes will continue. And stigma and all of the things that get wrapped up in it are hard, but we have to come together. Suicide is now the second leading cause of death for all people 10 to 14. And I think about my son, and he's 3, and what he's up against in his life, in spite of all of the privilege and power that he has and that we have as a family. This year, the Trevor Project, which is a wonderful resource, they're a crisis intervention advocacy group. They do an annual survey looking at LGBT resilience, LGBT youth health. 45% of LGBT kids in America, that's 1 in 2, considered suicide last year. And there's a lot that's driving that. And the Trevor Project, which 24/7, 365 days a year, they are available online, on the phone to support youth. They were called out by an online harassment campaign that was solely designed to flood their online channels to prevent kids from having access to services, with a very deliberate attempt to harm these children. We've seen death threats to people in my immediate community who are trying to provide appropriate evidence-based care, and these attacks are disheartening. And the fringe elements in society who now feel empowered by the political current, the climate, they win. When we allow this intimidation and violence to be unchecked, when we allow misinformation, disinformation to be spread, and that's a lot for anybody to take on. And George can't do it by himself. I can't do it. We have to do it together. We have to do it collectively as an organization. That's why organized medicine, the AMA, ACPM, Robert Wood Johnson, collectively we have to redouble our efforts to make sure that we chart a future that pushes upstream as Mr. Dawes encouraged all of us to do, and I am so happy to be here to help try to think through what that can be for all of us collectively to do.
Let me follow up with you on something that George put into the conversation. He says, we have to believe and we have to learn from our successes. How is it that you, sir, with your concern for equity and the things that you stand for, are now the president of the AMA? Is there something here that starts to signal a sea change in the way organized medicine and the physicians that would traditionally find their way to the AMA are starting to view their profession?
I think there is. I am a little bit different than my predecessors, and it's not just my hair, my great skin tone. I moisturize every day. I know there's a dermatologist sitting in the audience. But I wear this pink tie with pride. As the first LGBT person on the AMA board, and now as president-elect, as a very young AMA president. When I look at who makes up the physician community, it's still not representative of our nation. 12% underrepresented racial and ethnic minorities, and that's compared to 30% of our nation. We are making strides, and I think I've seen that in the 20 years that I've been involved in the AMA. I still remember pushing for a committee to work on LGBT health equity issues 20 years ago, 15 years ago, and being pulled aside by a mentor and said, Ehrenfeld, I'm not sure that's a good idea. Sure, it's important, but, there may not be a place for you at the table if you do that. And I said, you know what, it's the right thing to do. And here we are. So I remain hope. I know that we have a lot to do. I know that the pipeline is not there, that the pathways are not open, but we're going to change that. And I'm certainly committed to doing that from where I sit.
Well, Sarah DeGia, you've had a lot of time to realize that you are, in fact, the CEO of Change Lab Solutions, that you apply your legal expertise and leadership experience to advancing equitable laws and policies that ensure healthy lives for all. I'm really pleased when I read about Change Lab Solutions that you've established new partnerships to uplift health-promoting policies in rural America, assist community efforts to increase affordable housing, strengthen resiliency and the opportunities for children and families, supporting public health agencies and equitable enforcement, and expanding innovations in equitable and sustainable food systems. You sit on the Advisory Committee for the Office of Health Equity at the California Department of Public Health, the Advisory Council of the Healthiest Cities and Counties Challenge, and the Editorial Committee of Public Health Watch, among many other affiliations. You've heard a lot of this conversation. What are your thoughts?
So thank you to Donna and team for the invitation. I'm really happy to be here in DC honoring our leaders in equity. I've had the privilege of being able to be on being a co-panelist with Professor Dawes and have followed his work, and so you've chosen a really great person to honor here today. So in my work at Change Lab Solutions, we're a national nonprofit organization, and we use the tools of law and policy to try to advance health equity. And what that means is that we partner with communities across the nation to really improve health and opportunity through all of the areas that you talked about by changing harmful laws, policies, and systems. And so I'm the lawyer in the room that's going to help you understand what is your role in all of this, and in particular, how can we use the tools of law and policy to make change. So I'm going to pull on some threads here that I heard today and kind of uplift them, because we're all here because we care about health for all. And the perspectives that I really want to touch upon are these around structural inequities. What does this mean? And kind of start to pull that apart a little bit. And I want to first do that by talking about the definition of health. So when I look at the definition of health, the one that particularly speaks to me is that it's not just the absence of illness or infirmity, but it's the complete physical, mental, social, and cultural well-being. And lack of access to health care and our individual choices, they play a role in that complete vision of health. But the data shows, and we all know and have talked about today, that it is actually the institutions and structural forces that are all around us that shape the opportunities and resources that we have to thrive or survive. So structural inequities or barriers are a huge challenge because they're patterns, practices, policies, and privileges that are woven into our systems and norms. Again, often they show up as these neutral laws or these neutral policies on their face. But those are oftentimes actually insidious relics of slavery, segregation, and other kinds of exclusionary tactics that have been used, carving out whole proportions of people or whole groups of people to not be able to take advantage of the benefits of certain laws and policies. So our timing, again, kind of pulling on that thread of the time, it's perfect because we're here today because we need to be talking about these issues. And all of my panelists, I've been here cheering to hear about all of these efforts because we can't go back to normal. There's no way that we can treat our way out of health inequities. We have to operate, invest, focus, and design our systems far differently, and in particular with equity in mind and at the center. And that requires new ways of thinking. It requires cross-cultural or cross-sector collaboration. It requires leadership, and it requires government coordination. In my humble opinion, the key tools to all of those are laws and policies. And we know that communities want to make change. We know that governments, local governments, oftentimes want to make change. People want to do this, but the question is, well, how? How do we operationalize equity? So Change Lab Solutions has put forth a framework as well to think about structural inequities. And we call them the 5 drivers of health inequity. Professor Dawes talks about the political determinants of health. They're really one and the same. There's a lot of different things that we call these. But it's based on our 20 years of experience of working with local governments and local communities, academicians, clinicians, to really think about this work in an interdisciplinary way. And that's important because there's not one entity or one agency or one sector that's going to arrive at the structural change. We have to work together. Our systems are integrated in such a way. Funding is siloed. People hold different types of enforcement opportunities or activities. And so we have to be speaking the same language. We have to be looking at these things together. And so what we've done is try to draw on these different disciplines to, again, put forth some tools for change. Because we know that while laws and policies have been used to create and reinforce racism, they are just as powerful tools to be able to create change. Why? They create our programs and services. They focus on the distribution of power, resources, and money. They determine who's eligible for programs. They give government and us the ability to protect people's rights. They have the ability to affect so many more people. And they also often have a chance to address historic harms. And most importantly, they engage change makers, from community members all the way up to policymakers. Everyone has to be all in on this change. And I can just name a few great laws like Medicare, Medicaid, the Affordable Care Act. We've talked about those today. So the last thing I'll say is that laws and policies alone cannot affect change. You have to couple law and policy with the communities who need it the most, because otherwise they are just shells in themselves. They have to be informed by policy. I would also argue, and George and I were talking, Dr. Rust and I were talking about this, that you have to engage public health as well, because public health is in itself interdisciplinary. We're drawing together all these different disciplines to really think about the population's health, to think about the role of the environment, our institutions. And so public health in themselves are really well positioned to partner with healthcare, the healthcare sector and beyond, to really be able to center these laws and policies. So I'll end with saying, again, we have to be thinking structural. We can't just focus on small little policies here and there. We have to look at the big picture. We have to redistribute resources, power in particular, and money differently. We have to think about being interdisciplinary. Again, we have to look at it all together. Most importantly, sharing power with the community. We're trained in a certain kind of profession. We have certain type of knowledge, but we don't know communities like they know themselves, and they often have the solutions. So we need to walk hand in hand with them. And lastly, we've got to train our future leaders. They have to know how to work differently. We can provide that kind of guidance, but also bringing them to the table, like Dr. Ehrenfeld, to really help us bring different perspectives and thoughts to the table and not shy them away as thinking, oh, you know, you're too young, you don't really know what's best for you. We have to bring them along with us.
Sarah, let me ask you to join a dream of mine. It's a good dream. It's R-rated, or X-rated, and PG-rated, whatever the right things are. I don't know what they are. I have been, I want to just see how serious we're going to be about what you've said and what Daniel Dawes said. And I really want to get to how big this dream can be. So in a couple of weeks, we'll go for the midterms. And we'll go into the little room and pull the curtain. And we'll get excited about the Senate race, the governor's race. But then there's all these weird people down ballot who you're lucky if you even know, recognize their name, and hopefully your spouse has done the homework and given you a cheat sheet. And you just check, 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 check. What's it going to take for us before the election to have a little cheat sheet where we go and survey every one of those down ballot people about what do they think about this policy, this law, this rule, this engage? When are we going to take over the local school boards with the kind of science-based education as opposed to them not allowing us to even get past evolution? My question to you is, what's it going to take for all of us to decide to get involved in a serious way with the people who are making those decisions, not even for us, but just somehow magically they just do what they do?
So I have 3 responses. First is there is a role for every individual and every organization in this fight. Some folks want to believe, like, I'm a C3, so I can't do advocacy. That is not true. You can do advocacy as a C3. Oftentimes you can't use your CDC or federal dollars. Sometimes you have to be careful about how you use foundation dollars. But if you have donors, if you have unrestricted dollars, every organization can do advocacy. And that can be as little as saying Me Too and signing on to legislation to writing legislation or getting engaged in policy. The other important piece is educating or connecting with policymakers, getting to know them. Politics is local and politics is about relationships. And so building relationships with policymakers, getting to know, they're humans, believe it or not. So getting to know them and understanding what do they care about, who do they listen to, what is a really important way for them to see what your issue is and how it affects their constituents. So that's one thing, there's a role for everyone. The second thing is, oftentimes local solutions are really, really important because that's where people feel them the most every day. They feel the school districts, they feel the local public hospital or the local hospital. And so getting engaged and getting to know local officials or getting engaged at the local level is really important. They're laboratories for change, right? Yeah. That's a really good place for people to get involved. And then the last thing that I would say is that right now, we are facing an unprecedented attack on public health officials in particular. So we saw public health officials step up decisively and quickly during the pandemic. They reacted in ways that helped them save millions of lives. The problem was, one, we were in uncertain times, and so we were testing and piloting and pivoting based on all of that training. But the big key challenge was that there were policymakers who stood in the way of their ability to take action. And that continues into today. So we're seeing that kind of law or that kind of authority being stripped away or threatened from public health officials, which means that as we go into the next pandemic or we face the next waves of chronic disease or illness, our public health officials are not going to have the same kind of tools. So getting engaged and standing up for public health officials through Act for Public Health is a way, again, everyone can get engaged in the fight, in the game. As an individual, as an institution, again, there's a role for everyone.
I'm glad for that answer. And I do hope, in addition, that you all will, you and Daniel number 2, will be able to do that, along with ACPM and others. Let's have something in our hands before the election that challenges every one of those people. And I need to know what to ask them. See, I'm not smart enough to know that I'm supposed to say, pay attention to rule number 308, which is actually determinate, because that's where the money siphons off either this direction or that. You know, we need sophisticated things to hold these people accountable. We've left that whole territory fallow, but you talked about public health, and thank God for, you know, every time you see a public health person, you know, you got to thank them, because, I mean, my goodness. What's it going to take, you've been studying this, Julie, for us to regain the public health trust of the American people?
Yeah, I think it was, I left governmental public health 8 months before the pandemic broke out in the United States. And so as the pandemic was beginning to play out, I sat from my office in Robert Wood Johnson Foundation thinking, oh my God, how can I not get back in there and start helping on the ground? Because I just knew this was going to be bigger and worse than anything we have experienced in our lifetimes. And it has truly played out to be that way. And as I watched it play out, I could see how there were some major problems in terms of communication up front in the beginning and the lack of clarity on who was leading the initiative. And I could anticipate this lack of trust that has truly played out. There's no way for us for governmental public health or for public health as a sector and as a whole to regain the trust unless there's adequate resources and funding made available to support public health. You know, you think about it, it's interesting because NPR and Harvard did a poll, we supported a poll that they did, and what they found was that the general public, more than 70% of the public actually believes that public health needs more resources. And they're also, 70% of the public actually feels like public health work is really important. And yet there's a lot less trust in public health than there is in healthcare providers, primary healthcare providers, or healthcare providers in general. So and when you look at the resources that go into the healthcare sector, I know, George, it's not a either or. It shouldn't be governmental public health or public health versus healthcare. It's they both need to be really, really strong. But healthcare sector gets, you know, trillions of dollars, and public health gets about 3% of that. And so really, why wouldn't there be more trust in the healthcare system than there is in public health when you think about the kinds of resources that are going to them? So I really think in any number of ways that what we need, and I saw this play out when I was in the city of Chicago, there'd be an emergency, a public health emergency, the pandemic, H1N1 many years ago, Ebola, big surges in funding, and then the funding would drop off. And then we'd have to scramble with the next emergency, and then there'd be another surge of funding. And that's what we're seeing play out right now, is this enormous surge of funding that's made available for 3 to 5 years, and the public health agencies have to spend the money, and then there's a cliff.
I am so glad you pointed that out. I wish we had time, but I would just quickly say that those of us who, in the last 2.5 years, have been doing the community-based grassroots work, you know, we're really seeing in stark, dramatic, bold relief what happens and what has happened when you have disease-specific funding. All these years, you switch diseases like every 6 months. Okay, now we're going to do diabetes. Next time we're going to do this. We're going to do that. And then we fund for the disaster here, and then we get ready and fund. And now all of a sudden, there's no infrastructure left. There's only one little piece of blade of grass coming through the concrete of the playground. There's no oasis. There's no building on it. And then, of course, what happens now is government runs out of the doggone money because Congress won't fund any more COVID work, and we've got nothing to do the bivalent booster in the next round. So we're all scrambling again, starting from scratch over and over again. Let's keep playing the drama that Julie laid out to you, and this river that's flowing 2 different directions. So I tried to set that up in my early comments. I believe, maybe, you know, just pie in the sky dreaming again, PG rated dream, that the clinical care apparatus identifies this person because of the great data and analytics by the health insurance company, who else gives it to you. You know who you got to deal with. And now we will begin to bring together the assets of the public health folk together with the clinical folks, and there's some boom magic. What's it going to take to make this upstream, downstream magic happen?
Well, I think that's one very specific example of the upstream downstream, and I'm glad you brought it up, because I do think that a shift to a value-based system and a shift to population health management in a way is an opportunity that we need to not lose. And if we stay in our silo of public health being only agencies named public health, we will miss that opportunity. But if we look to population health, I think there are opportunities there. We were involved in a population health management program with Georgia in the Medicaid program. They say in the first year of that program, we saved the state $100 million. There's money we're leaving on the table. Racial disparities in hospitalization rates in Georgia, preventable hospitalizations, hospitalizations for preventable diagnoses, $600 million a year. There's money being left on the table because of racial variation in outcomes. I can give a whole talk to the Chamber of Commerce using Six Sigma language and never mention the word social justice about variation being expensive, about being inefficient, that whether it's a racial variation, whether it's a variation of minoritized communities of one form or another, whether it's variation in outcomes for the poor or the uninsured, if we can begin to get our heads around the idea that population health outcomes are in everybody's best interest, and that when you eliminate some of those sources of variation, you make care better for everybody. You know, the quality improvement guru, Edwards Deming, used to say that your system is perfectly designed to produce the results that you're getting. Our system, unfortunately, right now is perfectly designed to get racially disparate results and socioeconomically disparate results. And so we do have to change that system. But in another sense, if we let our system become an outcomes-driven model in which we're measuring on a regular basis our ability to produce consistently good outcomes no matter which community we're serving, then that feedback loop has to drive systems change to get to those outcomes. And it turns out, Cone Memorial in South Carolina decided they had a problem with cancer outcomes being racially disparate. Black women were not completing treatment, cancer chemotherapy treatment for breast cancer at the same rates as white women from the large region that they served. They did a lot of things. One is their CEO went and apologized to the African American community for their years of segregation, but they also invested money and resources, figured out some intervenable points where they could make a difference. They, about 10 years ago, eliminated disparities in that process metric of are people completing chemo and completely eliminated the black-white gap in that for all of their patients. And just in the past 2 years, they reported results where they had completely eliminated the mortality gap between black and white individuals from breast cancer within their patient population. And the mortality outcomes for whites went from 92%, the survival went from 92% to 94%, even as the black-white gap was eliminated. So it's not a zero-sum game. If you make care better for everybody, if you achieve consistent results for all communities, and maybe especially for those communities with the greatest challenges in healthcare, then you make care better for everybody, you get to better outcomes. So I'm a big fan, actually, of what you were talking about, which is micro data at the most granular level you can get geographically, temporally, racial, ethnically, with rapid cycle feedback loops, and then democratize that data so everybody can see it.
By the way, you mentioned disparities earlier, and I just want to, closing gaps, I want to make sure everybody does realize that when it comes to primary series COVID vaccines, the black community, although they ran a race with an anvil on their back and old combat boots, tied Leave It to Beaver with the newest jogging suit. We did close the disparities gap on primary series, and that's proof of what is possible, and that's why you got to believe. But let's stay in this bi-directional river. When I was privileged to be to run the medicine portfolio of the AMA, which still shocks me that I had that opportunity to do that, they were buying up a lot of land in Chicago, all around their building. They just owned all this land. You, sir, are part of an AMA that is investing in the community of Chicago, but it's not land. What are you doing?
So we know that if you look at any metropolitan area, there is a significant gap between life expectancy in the wealthy neighborhoods and in the poorest neighborhoods. And so on the west side of Chicago, in the AMA's headquarters in Chicago, a person lives 17 years less than somebody in Chicago's wealthy neighborhoods. And so 2 years ago, the AMA decided that since Chicago is our hometown and has been for 175 years, that it was time to invest and do some place-based investment with community partners. And so we invested $2 million in West Side United, which is a really impressive collaboration of civic leaders, residents, healthcare players, community groups, faith-based organizations, to come together to restore the economic vitality, educational opportunities, generate local investment, try to create corridor redevelopment, affordable housing, capital improvements, things that we know lead to healthier lives, to start to chip away at that 17-year gap. And so we're going to do some follow-up investment on that work, so to be announced soon. And if we're successful, we hope that this can be a model and an example of how we can start to improve outcomes, narrow that life expectancy gap in similar communities across the nation.
Beautiful. Well, let me just ask you this, Sarah, this question, and then I'm going to let everybody know we're almost at the end, and you're going to get a chance to do a 30-second lightning round of the one thing you said that was so brilliant you want to say it again, or the thing that you didn't say and you'll kick yourself in the behind the whole way home because you didn't say it. So get ready and it'll go that way. But can you give us a couple of examples or one, at least maybe one example of something that worked well, where we actually saw the legal and the health come together?
Yeah, so we've been working with healthcare institutions for a long time because, again, we believe they're really important partners. And oftentimes what we find is that there's perceived legal barriers or policy barriers that are kind of lifted up as like, we can't do that because that's against the law. And so part of what we use our tools for law to do is to actually help people dispel and really understand what are the laws and policies and how you can work with them in order to make change. So in the food area, for example, we've been able to work with healthcare institutions who are actually partnering with local BIPOC farmers to actually provide healthy food through to their patients through the diabetes prevention program. So there were a lot of kind of barriers and challenges that they had to overcome to be able to get that. But rather than only offering these patients 6 months of healthy foods, they can now extend it out years and years. We've seen those same institutions be able to partner with food banks and farmers markets, again, to get over some of these perceived barriers. And we're also seeing healthcare sector partner with housing partners as well. Not all healthcare sectors can invest in housing themselves, but they can be a part of the process. So we've seen in Denver, for example, and many other places where healthcare partners are actually at the table, helping to facilitate community engagement, helping to bring community residents to the table so that they can listen and invest their dollars in a way that's actually going to make a change. So those are just a few examples. There's many more, but I think it's just the tip of the iceberg of what more we can do to use that role as influencer from the healthcare sector, which has tremendous influence and resources and data to be able to make even greater change.
Wow, that's just terrific. I just think that that Daniel has done us a real service by, you know, it used to, I used to get so frustrated when I would think about how many years we have been talking about food deserts and how many years have we been talking about the need to address how do you get fresh fruits and vegetables into the community. But I could never figure out or understand why what the economics, the business is of why you can't put a grocery store, a liquor store you can put in there, a McDonald's you can put in our community, but you can't get a grocery store. What are the mechanics, how much of that is redlining by insurance that won't give you that? How much of it is that whatever it is. And so I think it is, I think what you are doing and what Daniel is doing is to get us beyond continuing to celebrate and recycle the problem, but getting down, as we say, to these root causes of what's happening. Well, actually, you have a minute instead of 30 seconds. But I'm going to start with you. And again, if you would think about what, through the prism of ACPM, this incredibly well-led by a terrific CEO, I'm so proud of you. I really am. We have a well-led organization with a lot of really, really energized people. And so out of the things that you all have thought about up here on the stage and reflect on, thinking about what we say to them, what's the thing you said that you want to double down on, or the thing you didn't say and you'll kill yourself because you didn't say it?
So I'm going to take advantage of this opportunity to push back on something you said.
It's gotta go. See you.
Oh, no. Sit down. So what you said was that the disparity in vaccine coverage levels that we saw be eliminated with COVID was because we believed. And I think believing is really, really important. But it didn't, that disparity did not diminish and was not eliminated because we believed.
That's right.
It's because there was a commitment from this administration to look at the vaccine distribution program and make sure that it was equitable. And it meant dollars were put into the community by way of public health, by way of the healthcare sector, by the way of nonprofit organizations to mobilize community, to promote and demonstrate and advocate for vaccination within the communities, not just addressing hesitation, but making sure that there was adequate access to the services, so the community was given the vaccine in easily accessible ways. Barriers were eliminated, and people of color were advocating and promoting from and within community. And so it was not because we believed, but because there were adequate resources that were put in place to make and to create the systems that really allowed people to be vaccinated. And so I think that's a really important thing. And I'm concerned that we have this great moment right now where the health equity is top of mind for everybody. Everybody's declaring racism as a public health emergency. But unless we continue to sustain the resources for public health in an ongoing way, we are not going to sustain that commitment to health equity. So I think that's the message that I would want ACPM and many, many others to hear, is we have to keep that drumbeat alive. We have to keep advocating for health equity. We have to keep advocating for adequate resources for public health so we can keep this progress forward and so we can see more health inequities, health disparities eliminated.
Well, I feel that, let me just, even though I'm going to come around and get the lightning rounds, but I think this point is important, and I think it is part of the agenda for the organization. I did get to speak truth to power to the Secretary of HHS on this very point, and I did say to him that, that we proved that the money was not a handout. It was not some gift. It was, we took the money and we used it, and I was part of that. And so, but here's where reason why I'm coming back on that is because I think you're so right. We are saying to the CDC as loudly as we can say, to HHS and their other agencies as loudly as we can say to them, stop giving us this piecemeal money that comes through some gigantic white organization that's the bundler, and we walk around like a character in Oliver, please sir, can I have some more? No, we want to be at the table. We want to be steady funding, and we've called for, right now, at least initially, a $100 million fund that will be able to create some basis for infrastructure and then build it over millions over the future. So I completely applaud you on that point. It takes belief, but it takes a lot more than that. Good on you. Sir.
I would just build off of what you said. I really want to just sit here and applaud it. But I think we've got to get the money and the power right. And starting with making sure that the power and the money are in the hands of the people whose problems we say we're trying to solve. I see in the university setting so many of us getting $10 million, $100 million grants and trying to work on community engagement because we haven't been so good in that area before. And my response to that is, what if you gave the $10 million or the $100 million to the community and let them decide how useful the university is in that equation? Now you'd have a conversation, right? And I think across all of these power dynamics and all of these money dynamics, we are working in a non-white world. That's always been true globally. It is increasingly true in America that we are a non-white world, but we have historically white institutions that have grabbed up the money and power.
That's it.
And until our institutions learn to be truly non-white institutions, which means money and power in non-white hands, frankly, to serve a non-white world, a diverse world, then, and that goes across all the other domains of diversities, then we're not going to get it right. We're just playing at the edges.
Jesse.
You know, in my role at the AMA, in my day job running a health philanthropy in Wisconsin, something that is always top of mind for me is when we partner with an organization, a community group, an entity, a religious outfit, do we take from them or do we give to them and leave them better than they were when we found them? And I would say that unfortunately the answer has actually not been yes. Much of the time, we have partnerships that are not truly bidirectional. They're not truly partnerships that invest and leave organizations with better capacity to withstand the long-term challenges, but rather get some work done, move on, and then gut the infrastructure, the people, the energy, the enthusiasm, the capacity to do work. We've got to stop that. And I think the AMA, through our Center for Health Equity plan, our work to embed equity, has finally figured out how do we start to measure some of those things. And I would just encourage all of us, as we think about how do we change that power dynamic, to keep that top of mind so that we leave all of our organizations, all of our communities, all of our partners better than we found them.
You are truly a leader for our time, sir.
So I'm usually the one who leaves with these messages, and so I'm a little speechless, I have to say. I really appreciate my colleagues saying that, because I do strongly believe that engaging community is good for health and it's good for public policy. And sometimes the way in which we do that can often leave communities feeling kind of taken advantage of or not in the best position. And so my 4 sort of quick points are, create an equitable process and really compensate folks as experts in their own field as you're bringing them to the table, and build capacity bidirectionally. So we need sometimes capacity to understand what it means to work with community or community-based organizations, and they often need or to understand what's our language or what are the systems and structures that we're working with. And so that's a way that you can also build that trust and bidirectional giving. The other thing is understanding the roots of the problem. So we can't just start with today's historic situation. We can't just start with today. We have to go back and look at the historical harms that our institutions have done to communities and how do we build back from those? Maybe it's a truth and reconciliation process, as the AMA or others have done, but we really do need to understand what's the historic context for all of this. And then we can move forward to figure out how do we align our resources in a way that we're building that shared partnership and that power sharing.
Ladies and gentlemen, this is the moment for transitional change. This is our moment. Please thank the panel. I'm going to go. We'll do this really rapidly. Yes. Oh, wait a minute. We're going to get the microphone in. Good. We're going to go real fast.
We've talked very little today about geographic disparities, and I'd like to ask the question about how can we improve rural health, and what technologies and innovations can we use in order to do so?
Good. Who else would like to take that? Rural health, technologies to get engaged for rural health.
I mean, I can start. One of the things we saw play out with the pandemic, there were some things that were successful in the pandemic that need to be sustained. And so the telehealth type of services that became available through the pandemic were unprecedented. So whether it was just primary care services or whether it was educational opportunities, but they were not necessarily rolled out equitably. And so I think that there really needs to be continued support for telehealth type of services as we move forward. And when you look upstream to the telehealth services, you really have to look at internet availability and accessibility. And so there needs to be a lot of shoring up of the infrastructure that we have within our rural communities so they can really take advantage of the potential opportunities they have for telehealth services.
George, you got a job doing this.
Just to add to that real quick, mental health is another area. We haven't talked much about mental health today, but when you look at access to mental health services, rural areas particularly suffer. Mental health emergency room visits dramatically higher in rural areas because of lack of access. Telemental health works in that context. It's also excellent across linguistically diverse populations. And so there's much that we could do, but the rural opioid crises and the rural mental health crises would certainly be areas where we need to do better investment. And then training clinicians in the communities that need the most. Training, I'll just speak in my own profession, training doctors in centers that will train them to be subspecialists we don't need, to serve communities that don't need them, and to look like me is not a particularly helpful investment of America's dollars.
Yeah. But wouldn't it be also that, and I think that your question opens up the great moment of, again, this larger American conversation where our interests may be aligned, so that the for lack of a better word, a Trump Republican rural person benefits from African American advocates for telehealth infrastructure, so everybody sort of wins. I think the disparity, the training issue for doctors is important, but I think the biggest challenge ahead is the training of people, because now that the world is going to be hospital at home, and now that we're going to have all the digital monitoring and all the devices at home, the competence of the average family to be able to handle and manage those is going to be the key. All this wonderful technology, what the hell do I do with it? So I think it gives opportunities. I think you want to comment?
Yeah, I was just going to say that telehealth has been really important. We need to maintain it, but it hasn't solved the specialty access problem, and that is not a technology issue, it's a payment systems issue. So in the state where I live, it's 46 days if you're at a fellow qualified health center to get to see an OB/GYN if you're pregnant. Waiting 46 days when you find out you're pregnant to get in to see an OB/GYN does not seem like an appropriate thing to do, and yet that's the state of affairs because we have a lot of these structural challenges.
And then from a legal point of view, the legal stuff that gets down to the payment for telehealth and whether that's going to be sustainable post-COVID and those elements is also going to be a determinant step, won't it?
So we're involved in a collaborative right now where we're looking at different rural policies that in particular would not only, and it's actually funded through Robert Wood Johnson, but it's not just about how do we get economic development and structural racism together, because we want to make sure that we're addressing those communities. But one of the things that we're finding is that there's a lot of dollars that are flowing to rural right now. Part of the problem is there's no capacity within local governments to actually receive and spend those dollars. And so that's one thing that we're looking at is what would it take to build some of that infrastructure and capacity to be actually able to use those dollars and spend them at a local level. The other thing is data. Data generally is not great, but in particular in rural communities, it's even worse. And then I do think that there's some policies that are blanket policies that would work really well in rural communities, and part of it's how we talk about them. But the other thing is how do we get them a little bit more specific to the geographic needs of those particular communities as well. More to come. We have some reports coming out.
We have 2 minutes to do one last one. Good. Well, we got to get the mic to you. Bracing of the mics.
Hi, thank you. I'm Jennifer Bright. I wear a lot of different hats. The comment about we need to move toward a value-based system immediately made me want to ask a question. So in my Uber on the way over, I read an article that listed out all the VC investments that Optum, Aetna, Elevance, whatever, the laundry list has made over the last year. Billions of dollars, basically. And Julie, you made the comment about resources, that we need more resources at the at the ground level. But I think one thing that hasn't been addressed today is the elephant in the room is that there's this business infrastructure that is the ultimate power structure. And it is currently driving a conversation about value that has nothing to do with anything that you talked about, mental health, LGBTQ, public health. And I worry in my professional life and all the clients that I work with that we're doing all the good work. We're thinking out of the box. We're thinking about community level, and we're trying to build it from the bottom up. But the bubble on top is going to keep us pressed down. So how do we change that conversation?
Thank you.
Yeah.
I know there's not a quick answer to a very complex question, but let's just take one and see where we go with it.
Well,
by the way, a well-articulated question. Thank you.
Yeah, super question, a hard one. I would say there is a business case to be made, even for those folks that are focusing on dollars instead of equity, and that is that, again, the Six Sigma argument that elimination of variation, whether it's racial variation, whether it's genderized variation, elimination of variation in outcomes and elimination of preventable bad outcomes saves everybody a bunch of money. We're leaving huge hundreds of millions of dollars on the table every year by not addressing that. And so there is an argument to be made that rapid cycle data feedback loops, holding ourselves accountable to best possible outcomes for all subgroups, is a way to get to, it's the one place where both the economic outcomes and the human outcomes begin to align, that we have less suffering events, less expensive hospitalizations, and so forth. What we have to do is get those companies to move from a one-year ROI, where they're only focusing on the really sickest of the sick, to a 10-year ROI, where they're willing to invest a little bit more in prevention that will pay off over a longer time period.
Julie, last word.
Yeah, so I'm here in DC through Friday, and why I'm here through Friday is because I'm attending the Trade Organization for Life Insurance Companies to talk about impact investments. Because the foundation is really looking to expand what we're doing in terms of some of our investments to really put capital into community. And so we've already started working with some life insurance companies to look at how they can use their capital and put it into community to really improve affordable housing. And so part of it is really leveraging those philanthropy, leveraging the assets that we have to do impact, positive impact, and then bringing others along with us to invest in community to really improve health overall. And so we've made some progress with a few of the life insurance companies. We're looking to make more progress with them. So I'm really looking forward to Friday, because we'll have the whole audience as life insurance companies who might be interested in working with us to invest into community in ways that they haven't done before.
Let me finally, as we close out, mention that there's a major initiative that's going to launch in about 15 minutes, and I'm actually running to chair it. But we are close, and ACPM will be invited to be a part of this. We knew you were going to be here and couldn't join this. But we are, and Julie and I have talked about it, AMA will be there, and Helen Burstyn will be running to get to it. But we have a chance now to bring the entire health ecosystem together in one gigantic end-to-end effort to try to get at distrust, misinformation, and disinformation, and try to have every single sector of the health enterprise together. And what provoked me to think that is that it's going to be very politically challenging, because everybody's going to be, somebody, well, I can't work with this, or the pharmaceuticals don't want to work with the hospital don't work with the docs, this guy doesn't work. But I think we're going to have a chance tonight if we can pull this off. So I want y'all to pray for us tonight and see whether or not it is actually possible for the entire, from the ethics, the AAAS, Advancement of Science, Research America, Milbank, AHA, AMA, every single part of the health ecosystem come together and one time say to the American people, we are going to deal with this issue of trust, misinformation, and we're going to work together because it's core to our professionalism, our values, and who we are. So keep your fingers crossed, and we'll keep you informed and invite you into it. Thank the panel again.
Well, I must say, wow, this was a powerful panel, a powerful session today, and we're incredibly grateful to Dr. Tuckson. He's back by popular demand. I guess you all understand why. And of course, our panelists, Dr. Morita, Dr. Ehrenfeld, Dr. DeGia, and Dr. Rust, for their outstanding leadership in sharing their insights and their passion for the next steps of what we need to do, not only as a college, but also as a nation. It's incredible to watch the leadership, and I'm sure that Dr. Blumenthal is smiling as he's looking down. We heard Professor Dawes describe him beyond the words we originally used as an innovator, a trailblazer, a trendsetter, someone who was inspirational. And of course, you heard from the leaders of today taking the bull by the horns, if you will, and being exactly that. So recommending that we take on trailblazing activities, that we be inspirational and take on the leadership to make a difference in our communities and in our nation. It's interesting to hear, and there's a quote by John Wadden, that he said that to be a leader, the most powerful leadership tool that you have is your own personal example. And if you think about that, we all have a call to action for our leadership and our own personal example. Hugh Tilson, who is one of our own ACPM fellows and a former president of the college, also said that it will take more than one leader. One leader cannot do it all. And when you're leading communities, which was a specific call to action from this panel tonight, oftentimes you need to lead from behind. Can't lead from the front. So as I'm listening to all of the information that we heard today and to try to summarize some of the numerous points they made, I heard several calls to action. One is that we have to embrace health equity as the only acceptable outcome. That we are going to have to address structural barriers across the river, from the downstream to the upstream, but now a particular focus based on Professor Dawes' presentation on political determinants on the upstream factors. We also need to engage in true community partnerships where they're equally at the table, funded for their efforts, recognized for their expertise, and advancing what we're doing. And I will tell you, for someone who is engaged in NIH-funded community-engaged research, it is the most rewarding work I have done in my 30 careers as an academician and as a physician scientist. I also heard a call to action that we have to integrate our efforts. We have to look interdisciplinary, and we have to go across upstream, downstream, and across our disciplines. It's going to take all of us. It's going to take all of us, and we all must lead as leaders. So the American College of Preventive Medicine is fully committed to this charge, to these calls to action, to live on the legacy that Dr. Dan Blumenthal began for us ahead of the time, ahead of the trend. We embrace the challenge. We look forward to the opportunities and to engage each and every one of you in our quest to make a difference in our nation, in our communities, and in our own backyards. I want to thank everyone for being here this evening and to engage with us and also to hear a pathway forward. It's absolutely fabulous to have our expert panelists here sharing their insights and giving us a road to go and a road to follow. I also would like to make sure that we take a moment, just a moment of silence. I can't help it, I'm from Louisiana. And to see that hurricane barreling through the Gulf and heading to our neighbors in Florida, that we just take a moment of silence to think about those communities. And I will tell you that those marginalized communities will be the hardest hit, that the lack of attention to chronic disease management, to early cancer screening, to vaccine-preventable diseases will emerge in ways they never will see coming as that storm moves through that state. So we just take a moment to think of our colleagues, our friends, our family, and others in Florida. And lastly, to close this out, I do want to thank Dr. Mike Ibarra with Pharmaceutical Manufacturing Association, who provided the funding for our reception this evening and for their ongoing generous support as a Prevention Alliance member for the American College of Preventive Medicine. We hope that you all will all join us here in the reception so that we can all celebrate the honor and legacy of Dr. Blumenthal, as well as the fact that we're all here today unified in a quest and a mission to make a difference. Thank you all.
Thank you so much. It's good to be with you. It's really an honor to be here for the Dr. Blumenthal Lecture, especially with so many amazing people like yourself. I'm really excited to learn from you all and excited also to jump on the same call that Dr. Tuxson mentioned just a few minutes ago, representing pharma. My name is Michael Ibarra. I'm a vice president at pharma. I'm also an emergency physician by training and by practice, and still practicing today. And I love the comments about not reciting the problem, but thinking about solutions, and that's what I'd like to share with you all now. You know, Chicago, as was mentioned in the last panel, is not too dissimilar from DC. If you're from this area, you know that Washington's divided into wards, and 6 of the 7 hospitals are located north of the Anacostia River. Only 1 of the 7 hospitals is located south, where the majority of patients that suffer from chronic diseases, where there are a number of health disparities. We see it all the time in the ER. I could only just sort of imagine the ambulance that you heard just a second ago that have to drive 20 to 30 minutes from southeast and southwest DC to the hospitals in northeast and northwest. And so when I think about those problems from either the emergency department standpoint or from the industry standpoint, I always want to think of what's the solution, what are the things that we can do, how can we not recite the problem? And so PhRMA is an association that represents the industry, a number of folks here. I saw someone with the Takeda badge on earlier. What are we doing? What are the unique things that we can contribute? How can we be aware of our own blind spots? And there are a variety of things that we're undertaking, one of which I want to spend just 1 minute mentioning today. We realize that we have a unique role to play in making medicines accessible to patients and making sure that our clinical trials represent the diversity of the country, the US population, as well as countries around the world. So recently we announced a partnership between Yale School of Medicine, Morehouse School of Medicine, the Research Centers and Minority Institutions, RCMI, and Morehouse School of Medicine to effectively work together to address diversity in clinical trials. We called it the Equitable Breakthroughs in Medicine, but what we really want to do is put a community-based infrastructure in place so that patients can access clinical trials, can think about clinical trials, can be approached about clinical trials everywhere, no matter where you are. It doesn't matter if you are going to Georgetown University Medical Center, where I do my clinical work, or if you're a patient that's diagnosed with cancer or chronic disease in Southeast or Southwest DC. How can we put those clinical trials into the community? So even just getting to this point was years of work, but I think we all recognize that failure is not an option, and it's going to take a ton of work, a tremendous amount of work with partners like ACPM, and we so appreciate the leadership that you all show on these issues. We look forward to learning from you, to launching this program with input from everyone in this room. So we're so happy to sponsor this because we know that we need to partner with you to drive these initiatives forward. So appreciate the conversation today. Thanks for the opportunity to sponsor this, and I hope everyone enjoys the reception.